Welcome, everyone, to this session. So we've got a lot to talk about because basically, how can AI deliver maximum value to patient? We can talk for 40 minutes about AI. We can talk for 40 minutes about maximum value. Possibly you can talk 40 minutes about patients. So we're going to try to talk about a bit of those. But maybe I think my first question can to all of you to set the scene in terms of if we're talking about the maximum value, the best possible value to patient, would it be something that you prioritize, before anything else? Is it going to be, data, the patient in itself, in terms of mitigating the risk, in terms of integration of different technology? What would be kind of the number one thing you consider in terms of giving the maximum value and then thinking about AI? Laura, if I start with you.
I don't know if I have one answer to that. I have several things. But I guess for people who don't know who IPPOSI is, so IPPOSI is the Irish platform for patient organisation, science and industry. And just recently, we led a citizens' jury on the use of AI in healthcare to understand what are the public concerns, perspectives and value around AI in healthcare. And I guess what came out really strong from our jurors, representative of the population, was to demonstrate value. One of the building blocks and foundational elements for that is trust and trust in the technology. Transparency, I guess, in ensuring that involvement of patients and the public throughout that whole AI life cycle. And we have all of the metrics around value, around, privacy, safety, efficacy. But I guess the value is how does that impact on the patient journey? How is it improving the patient experience? And how is it, I guess, improving outcomes for them? And when I say for them, that's all. And I guess it's really important when we're talking about AI that we're looking at equitable AI as well. And that's, the value is for all. And so when we're co-designing solutions, we're asking ourselves, who are the voices or what are the voices that are not being heard right now? And that we work together with the clinicians, with patient groups to demonstrate and build that trust in AI, or else it just won't realise its full potential.
So trust, transparency, patient. Javier, what would you pinpoint as a key element?
Well, you asked a very broad question, and my answer is the end of all diseases. Yes, and why? Because if we are talking about AI and health, we should talk about the AlphaFold revolution. And the winner of the Nobel Prize, as you know, last year was Demis Hassabis, who is at the same time CEO of Google DeepMind. And not only that, he has launched another company, Isomorphic Labs, to end with all diseases thanks to AI in 10 years. And it's not me who says it's the Nobel Prize, by the way. But in the meantime, early detection, because we can talk about diagnostics, more precise diagnostics, better medicines, personalized medicine. By the way, I'm a patient as well, and I'm here thanks to all those things. And that's perfect. And releasing the burden of the system for clinicians to have more time with patients, all that is fantastic. But early detection, pulling all the data together from the patients like scattered around hospitals and countries to unlock hidden patterns which are invisible to the naked eye. And by doing that, not ending with all diseases, but decreasing the number of patients dramatically. That's my dream.
Early detection, ending all diseases, and I think you're right, AlphaFold, much more important than ChatGPT, in my view, in terms of AI development in the last 5 years. Ofer, what about you? Maybe outside of kind of a different perspective?
Well, yeah, I agree with Lauren as well on the development of trust. And it's a broad question, but at the end of the day, I think also one thing that's important here is the value of the data and how it translates into personalized care and personalized treatment. In the networking session just earlier, a person said, well, if you met one patient, you met one patient. And that's true. Like every patient by himself, and Javier mentioned this as a patient, and I think all of us have been a patient at some point in time. You want what's best for you. You don't want an aggregated tool. You want something that will be relevant for your treatment, that is specific to you as much as possible, that is relevant to your health and to your genomic background. So I think getting the AI tools today to give the most value in that sense in personalizing care can go a long way.
Thank you. Hernan, what about you?
I would say I am like what we see is like two realities. We suffer. I work in a pediatric hospital. We have a lot of thousands of patients with rare diseases or ultra rare diseases. Most of them takes a lot of years to get a diagnosis. Only 5% of them they have a specific treatment, and it's really hard to have a good assistance to the patients and the families. And on the other side, we have these kind of new technologies that I promise to help us to improve all the things. So I think we need to align it and decide where do we invest to put the focus and try to reduce this diagnosis time for patients, so we will have a prognosis, and then to incorporate new treatment for them. And at the same time, we have to do it with our own resources. That it means that we have to make really good decisions to incorporate it.
Thank you. And Alex, what would you add?
For me, it's definitely increasing access for support. So Kai is focusing on mental health, on emotional support, and I'm sure that everyone here in the audience knows someone who needs mental health support at some point of their life. There are not enough clinicians. The long wait lists are hurting everyone, and AI can be a real force multiplier when it works together with clinicians. The number one use case for large language models this year is emotional support and companionship. And to do that in a safe and ethical and trusted way, that's the biggest challenge. But the hope is that everyone will be able to receive mental health support immediately and at scale, and the AI can raise flags when more attention is needed, when a clinician needs to interfere. So that's very important.
So we've got trust, early detection, personalization, kind of diagnosis, timeline and treatment, and accessibility. You know, we've got 32 minutes and a half to talk about how AI can improve all of those. Maybe I kind of want to go on with something you just said, Alex, in terms of large language models and the facts. Obviously, ChatGPT, 30th November 2022, big revolution, big hype, lots of money being spent. Is it really kind of when we're talking about AI, we're talking Gen AI specifically, or are we talking about all kinds of older traditional AI? Or is it kind of a mix of everything? So therefore, you're going to have use cases where maybe in mental health, because of large language models, LLM and Gen AI is going to work better, but maybe for other type of things that you need to do within the healthcare sector, then traditional AI will work better. Maybe Alex, I'll go with you there.
Yeah, we see a mix. There are certain things like screening and triaging at large scale that not only LLMs can help, but identifying who needs more support and what's the level of distress. This is something that different models can do. But LLMs are amazing because it's very natural for humans to interact with language and voice. So we see many people that will share voice messages with Kai, and LLMs make that possible. And texting is very natural. My teenage daughters are using WhatsApp for messaging, but my parents are using it as well. Mm-hmm. So LLMs really unlock a lot of human-related possibilities, but I see a mix of models working together.
Everybody else seeing a mix, or is there kind of areas where basically Gen AI, it doesn't really matter and we're using the old type of AI? Javier?
Oh, of course, AI is a broad term, which involves not only generative AI, and I call it non-generative AI because some people call it classical AI. What is that? Or machine learning. Generative AI is also machine learning, by the way. So it's about putting together all the tools into your toolbox. And in many cases, generative AI cannot do some tasks. And you need both types of AI put together in a pipeline to solve a problem.
Yes, Laura. Yeah.
And I might just add to that, I guess, when we're looking, and I guess I'm wearing a kind of a public patient hat on me here, and I guess when we're talking about all these different types of AI, it's how do we communicate that in a way that's accessible to someone that's not overwhelming, but also being transparent around the limitations, because there are going to be limitations. And even clinicians need to understand the limitations. So I think it's all, these are all can be quite techie terms for the public. And I think, it's a role on organisations like ourselves to demystify all of this, make it accessible, but also taking into consideration the different health literacies and digital literacies of people as well, so that people can engage to the level that they would like to engage in understanding this space. So I guess if you ask what AI is to an academic researcher, to an industry, they'll give you a different application of AI. So
yeah, I wanted to ask a question. It's quite interesting because obviously the last 3 years we've seen that kind of hype and kind of public vision of AI, whereas before 2022, this is the first edition in AI in our summit, and I think this is the third AI in something summit that I've done this year. So this is why ChatGPT has done that. But I think it's interesting from your perspective that obviously you're looking at outcomes, and it doesn't really matter whether it's Gen AI, non-Gen AI, classical AI, traditional AI, non-AI, even, as long as you get the right thing.
I would say that when we were working with AI for many years, and we have a lot of problems with structuring data or anonymizing there. So LLMs are helping us to get this and to continue this growing in this trying to predict or to be proactive, to make better decisions. That finally is what we are looking for, no? And I would divide it, the access to ChatGPT or Gen AI, the part that we can control, and there is another part that we cannot control. In a hospital, we are looking many patients that are coming to the consultation not to make questions, just to validate if the AI insights are right or not with the clinician. So it's like this kind of conversation between clinicians and patients are changing too, because they are accessing to these kind of tools. So it's kind of, we need to understand these things too, because it's changing the models of how we relation and the relationship between.
So AI is changing the ways that patients come to you because they've looked at it on the internet and ask AI chatbot about, I've got this, what kind of disease it is, and you go see the doctor, I'm sure I have this, and then the doctor goes, well, maybe not. Ofer.
Yeah, it's actually interesting to say that, Hernan, because I think one of the biggest things that people don't talk about when it comes to Gen AI is around how much trust you have in the sources that they give to you. Like it's not like using a travel agent. You're talking about healthcare, you're talking about information for a patient, you're talking about information that a physician will see. And I'm sure you have examples of physicians in your network, how they use it, how much do they trust it, how much can they rely on it, how much can they use it as a tool when they refer patients to it. I think that is going to be the biggest hurdle for wide adoption. It's like, how do we know that it's trained well? How do we know if there's no bias? How do we know that it's trusted sources that we can use? As soon as we figure that out, the potential is huge. But it's really, I'm very curious to understand how physicians both see patients using it, but also use it themselves.
Mm-hmm. And maybe kind of, let's talk about that, because there's a lot, let's call it hype about AI, or it's magic, sometimes not. But obviously we mentioned the word trust quite a few times. We mentioned the term patient. So obviously you're looking at AI in terms of driving positive outcomes in terms of the healthcare sector, but it's not like you go to OpenAI or whoever provider, you say, put it into my system and then everything is fine and there's no issue. There are those limitations, there are those things you need to know about. And I think they're on both sides. They're on the kind of the clinical side, like on the doctor side, in terms of understanding, and also on the patient side. So, and I think it's kind of very important to know that if you want to make the best possible use of AI. So I'd be interesting to know how exactly you kind of deal with those limitations, with those kind of risk, while at the same time kind of putting the patient at the center. So AI is there, you're kind of using it to do different things, its limitation, its potential risk. We talk about bias, there's privacy, there's security, there's plenty of other things. So what do you do in terms of making sure that you use AI, which is not a perfect technology or not a magic technology, but can be a very positive technology in that positive way? So what kind of the practices have you found? Because it's still very early. I think if we do that session in 5 years' time, we'll say very, very different things. So we're still very, very in a journey, but it's still 3 years on. So I'll be interesting. Maybe Laura, I start with you.
Yeah, so look, I guess for the most part, when we're talking about trust, that clinician-patient relationship is built on trust. And from the jurors' perspective, and I keep bringing back to the jurors because this is coming from the public and from the patients, what they want to see was that human oversight. And that AI, again, just being, it's not going to replace the clinician. And so they're working in tandem together and really demonstrating that the clinician is working with AI almost like a GPS tool or something. It's not replacing any clinical decision making. It is informing a decision and the narrative around that. So that's possibly one way. I think what we have seen from in Ireland, at least, and this is all very new. Like we didn't have in Ireland a national strategy for AI, but we now have patients and public involved in developing the national strategy for AI in healthcare. We have patients involved in the implementation framework in national guidelines for safe and ethical use. And all of this will help in that trust. But I think it's the relationship, ensuring that everything's grounded in the empathy and we're not losing the human connection with AI.
So AI as augmentation rather than replacement. And maybe our friend Jeff Hinton was wrong when he said 10 years ago that all radiologists would be replaced by AI by now.
They're still there.
Still there. Same with self-driving car. For the past 10 years, they were coming and they're still not there. Javier, did you have anything to add maybe on that?
Yes. The relationship with the health system is about trust, as you said. And we trust our doctors because we know, we are sure that they have been trained and they have undergone some processes that takes them to the level that we can trust them. Yeah. What if we do something like that with AI? Why not? But first, we need to explain to people that what AI can do and what AI cannot do. And explain the benefits and the future of AI. And for instance, when I go to many places, I ask always the same question. Who knows what DeepSeek is? I'm not doing it, but I'm sure everybody knows. Who knows what AlphaFold is? I'm sure that not so many others will be raised. So we need to explain all this to the public and also train doctors, clinicians, researchers, and patients in AI. Because when you understand it, it's clear that the benefit is there for you to give you superpowers because it's your first line of treatment. You have access 24/7 to the best information, but not to replace your doctor, to become part of your medical team with your doctors. Because with AI, your doctor can be a super doctor for you. That's the idea, but it's not obvious.
I mean, is it coming, the super doctor? Or, is it like a goal that's going to happen in 5 or 10 years' time? Or is it going to be like self-driving car, where we've been talking about it for 10 years and it's still not there? Therefore, it's just a pipe dream and it's always a pipe dream. Or like AGI, if you want to. Is it coming, or is it going to be not so much a super doctor that knows everything, but a super doctor that knows enough stuff that a human doctor can use it to become a better doctor?
Exactly. That's the idea. That's the idea. We all, if you are using already GPT-5 thinking, the reasoning models, you become a better professional. You become a better moderator, probably. You become a better whatever.
They've thought about replacing me in the past,
Yes.
But it's true.
It empowers us. Yeah.
I can add two points. One is that some of the models are very good for validation and safety. So basically, before sending anything to a patient, you can really check that the AI is not recommending medication or recommending any risk life event, right? So this is one thing. You can use parts of AI to also work on safety. The number one thing, as Laura said, is having a human in the loop so that the human can intervene when there's a need. And the AI is very good in identifying risk points and asking for human intervention. And maybe the third thing that works very well for us is this ability to create synthetic data. So in real life, it's very hard to see many patients and edge cases, but with synthetic data, it's possible to say, hey, here is a nurse that just experienced a loss of a patient, and here is her engagement with the AI. Does it look good? Or here is a very different use case. So synthetic data helps us with finding edge cases and risk points and mitigating them before they reach actual patients. So,
Ofer, yeah.
No.
Ofer. Good.
So I agree again with what Alex said and what Javier said. What I think is also interesting, there was a session yesterday that talked about the burden of the physician. So there's less and less time that you have with a patient and more technology at your fingertips. One of the key things that we can do across the ecosystem in healthcare is to make sure we have good standards and values and put in a responsible AI framework with the right data architecture so that when a physician uses the tool, they know that that's been validated. They know that they can trust it. They don't need to think about, can I trust this? Can I put this in front of my patient? Because to your point, the doctor of the future, what does the doctor of the future look like? What tools are they going to have at their fingertips? And how do we ensure that across national payers, across physicians, whether you develop this yourself or whether you outsource it from an external company, aligning on standards and aligning on data quality standards and ethical development, that you know that these tools are valid and you can use them with the human in the loop, to Lauren's point, like, that you can guide them, you can navigate them, but you can rely on them.
Yeah, I will add with this reflection because it's really interesting when we talk about AI or technology. If we put it isolated, it's like you are in the hospital and it's like you are losing the human and the culture part of the organizations where you wanted to adopt this technology, and you have to make all these part of the same photograph, because if not, then you're gonna see the clinicians running the whole day, attending patients, looking for their performance and their activity, and we promised them many years ago that digitalization and the new technologies will help them to have more time to connect with the patients, to have better conversations, and they don't believe it yet. I mean, you have to work with them to implement this kind of technologies. It happens to us because we were for the last months we are trying to implement scribing, the voice to text transcriptions and then summarization of the consultation. And sometimes when they found only one word that it wasn't there in the conversation, it's like, this is not working. I mean, so it's really hard sometimes. It's easy to implement the technology, and it's really hard to get them an understanding that they are not the ones that they are writing the electronic health record. They are now validating, and it's completely a different mindset for them. So you need to understand that from their point of view to get a good adoption.
Yeah, I mean, the world is changing because of technology, and it's about making sure that doctors can use it as much as possible. I mean, we talk about human-centric education not just for the doctor, but also for the patient. Just don't Google your symptoms and hope that Google is the doctor, potentially. I want to remind our audience that we'll open it up to Q&A, and because there are quite steep steps for my colleagues to go up and down, so if you have questions, please raise your hand. I'll try to open it up. You've mentioned, I think all of you, and also before when we kind of prepared the session in terms of data. So Alex, you mentioned kind of synthetic data. We're talking about AI, we have to talk about data. So I guess my question would be, what kind of data are we talking about? Because I think in terms of healthcare data, there's a lot of different kind. And also, what are the best way to kind of govern the data or to share the data? What kind of the best system to put in place? Because we're talking about very sensitive data, and you don't really want very sensitive healthcare data not to be as secure or as private or as protected as it could be. So what needs to be done in terms of, I guess, that first stage in terms of making AI more powerful and more transformative, in terms of making sure that data is, one, available, and two, secure and private. Who wants to go first? Laura, you want to start?
Well, I think you're a little bit ahead of us in the UK in terms of data digitalisation. We are starting on that journey. So we're very excited to be at a situation where we're now really implementing national electronic health records, because that has been a huge barrier. So data has been siloed in Ireland for years, and it possibly siloed in many, many places, but data has been siloed. It's not been standardised. In terms of the quality, possibly there needs to be a validation on it. So I think it's looking at, first of all, ensuring that we're capturing standardized data that can be merged. The other would be really strong governance structures around access to that data sharing. I guess from conversations that have happened in Ireland is, sharing that data with industry, and what conversations do we need to have with that to, again, build trust between public-private partners. So that's a whole other conversation as well, because obviously industry play a huge role in development and drug development. But I guess it's having your processes, your governance structures, and what we would really kind of advocate for is having public and patient representation on those governance structures. And again, that's all around, I know I keep saying it, but it's all around trust and building trust. But if we could get our systems talking to each other, that would be
So start, let's try not to make let's try to make the data digital.
Yeah.
Let's try to make it not siloed, and then we can move on in terms of trust. Javier.
Yes, I agree that trust must be there, privacy, security, all those things. That's very clear. But first of all, we need to have the conviction and the willingness and the knowledge and the opportunity to share those data, because science is advancing so rapidly that, for instance, some years ago, you talked about cancer as a broad term. Now you talk about certain organs cancer, and now certain mutations cancer. But chances are that if you are one of those patients, there are thousands like you in the world. And if you don't share those data, chances are that your doctor has only seen you in their entire life. So first, I think that the conversation is probably too much on the side of privacy, security, etc. But I don't hear and listen to many conversations talking about, let's share data. Let's share it. Because it has benefits. We have to do it. I don't hear that much.
Mm-hmm. Does everybody kind of see the same thing in terms of the data is there, but it's not available and it's not shared in a way that can be useful?
I would say, I mean, we work with rare diseases. Most of our patients are rare diseases. They have their rare disease. So we understood many years ago that we cannot work alone as a silos because we don't have enough number of patients with a specific disease. So we start working how to share data with different hospitals, in our case, in Spain, but with other countries. So this is part of our work, and this is the dark part that nobody see because it's not very cool things, but how to share, harmonize this data and put it in a architecture that we protect that data. We are not duplicating that, and at the same time we can work and process the data, sharing with other hospitals, professionals, or companies. So for us, it's kind of our NDA. It is really, really important but for many years. So we're still working in that way.
Yep.
Yeah, I would add that your first part of the question was, what is the data? And hearing from all the excellent experts on this panel, the sharing of data is only one piece of it. The other piece is what is the data that we collect. Since the panel here talks about the maximum value to patients, it's amusing. I'm looking here, and like most of us don't have a smartwatch, but the majority of the people do. And you're able to collect relevant patient data from all the way from a pediatric patient with a rare disease to an older patient with a chronic disease. And that becomes the data sharing that you can build personalized tools for. So I think that's the one thing that in many cases is missing. It's like, how do we think of the broad data as a term? How do we add more data to the considerations? How do we incorporate this data in a solidified way across medical centers, across whoever needs to decide on our treatment, whoever needs to decide on our care, to get the maximum information? Then how do we analyze this information the right way to make it really personalized?
Alex, yep.
Yeah, I would clearly separate two types of data. Not all data is the same. So on one hand, there is the personal conversational data, and this is always encrypted, depersonalized, no access to anyone. We work with SOC 2 certifications for data privacy, and this is key for trust. Otherwise, no one will trust it, and we see high levels of trust because of data privacy. The other type of data is aggregated anonymous data, which can be very, very important. For example, Kai worked with over 200,000 people so far, and we could show during COVID that the levels of anxiety here in London are lower than they are in New York at the same time. Or when we started to work in Ukraine, when the war only started, we could show a general view of what's happening on emotional distress for those people working with a service like Kai. So aggregated anonymous data can help decision makers, can help with resource allocation, and personal, private, conversational data, no access, encrypted, always private, and I would treat them completely differently.
Javier.
I think that in general, people aren't as reluctant to sharing their data as we think, because we do it all the time with our social networks. Our data, yeah, we do it all the time, and we don't care. We expose our life, we upload pictures, everything. So I think that from the healthcare system, probably we are supposing things that maybe aren't in the patient's minds. Because, of course, if data is anonymized, what's the problem?
Yeah. I mean, you're right. I mean, we share data. I mean, even today, if you think about, thing you shared this morning in terms of where you were with your smartphone, with your tube pass, with your credit card and whatever, all that is going to somewhere. But when it comes to health data, there seems to be a bigger barrier, perhaps rightly, because it's much more sensitive. But in terms of the possible advantages, there's something there. I want to open it up for questions. Oh, we've got quite a few. Wow. So I'm going to take a few at a time. So gentleman over there, then I can't see because the light is right in my face. I can see some arms, but let's start with the gentleman there. Yeah, well, you got the mic, so yes.
Yeah. So it's more of a reflection, really. Obviously, patients are the ultimate payers for all healthcare, be it directly, self-pay, through taxation. And so you're looking at value. So with that perspective, obviously the productivity and the delivery of healthcare from a value perspective is an important thing for a patient to think about. And it's interesting that you've all sort of talked about other aspects, the diagnostics, delivery, access, but no one's talked as a patient, paying for care, that it actually is low cost. So I was wondering if you could reflect on that slightly. And to your point about, I am a doctor making super doctors of the future, I hope AI makes managers super managers, and that actually reduces the cost of healthcare going forwards.
Yeah, I can say something about it. So I have good news because people are actually using it. So again, like Kai worked with over 200,000 people so far. And we see two clear things. One is that people use it frequently. So third of the people will engage with the AI every single day. It can be only 1 or 2 minutes a day, but every single day. And their emotional well-being is getting better. So we published 2 research papers so far. We're going to publish 3 more. We see a clear improvement. After 4 weeks with working with the AI, they're getting better. So there is real benefit and real adoption, real usage. So this is very, very good news, I think.
I might just respond to the cost piece, which is a very good point. And in fact, AI could help almost break down some of the barriers around access. And some people might live in rural, even the cost to travel to a city for a consultation, all of that is a cost on the participant. So I do think you have a point there around how it could potentially while there's a risk that it could, lead to a health inequity, but actually, if you flip it the other way around, it could actually increase health equity. So yeah, good point raised.
Any other question? I can't see. So yes, over there, you got. Please.
Thank you very much to the panelists for the discussion so far. My name is Dr. Carrie Brubaker. I support medical affairs teams in biotech and pharma as they explore and achieve their digital transformation goals. We've heard a lot in this discussion, as well as through the day so far, about some of these elements of bringing audiences and partners along with us on AI or Gen AI journeys. What I haven't heard so much about is the change management element. And I would be interested to hear from the panelists your opinions or your thoughts on how we can most effectively partner with patients, because they are not a monolith, to be involved in that change management journey, to get them more accustomed to the idea of an agentic AI or an ambient AI being used during their consultation, or to help them understand what's going to happen to their electronic healthcare records in the event that these can be mined, de-identified, and used to develop further technologies. Thank you for your insights.
Who wants to go?
Yes, I think it's all about, again, it's all about education for patients and for, yes, answering as well to you, to the entire staff of the health administrations and the departments and hospitals, because this has the power to change everything. We all know that. That's why we are here, of course. But everybody needs to know this and be trained from the top to the bottom in the power of this technology. And it is not about just streamlining the system to make it more efficient. It's about making more efficient to give more value to patients. And it's a reinforcement loop that goes on and on forever. So both patients and clinicians and practitioners need to be trained. I think training in AI should be mandatory, not in the healthcare system, for everybody in every country. There are countries who are already doing this. I think that's very important.
All right.
I will add that in our case, in a hospital, we work, we design solutions together with the clinicians, technicals, and the patients, because it's the only way we can assure that every time we implement a new technology could really work. For example, for the last 15 years, we were working in a program that we call Liquid Hospital, because we understood many years ago that the children are going to be better at home, not in the hospital. So every time we can avoid coming to the hospital, it's going to be better. But at the same time, when we were adopting new technology in this same program, we were changing the relation between the clinicians and the nurses and the patients and the families. So we put all together, we work together with them and the technical part, so we can really be sure that we are generating many new connections, many new interactions that we have to understand and work in this case.
All right.
And just very quickly, I think it's a mix of dialogue and involvement to answer that question, and an openness to culture. And it just becomes the culture of embedding people throughout your whole processes. And for change management, often you need a champion at the top, kind of really highlighting this is our culture, this is important, and demonstrating the value. So that return of value and demonstrating it helps with that change management piece.
I want to add from our experience, and it's an excellent question and very important one, is that the patient is not the problem from our experience. When a psychiatrist tells the patient, hey, instead of waiting 3 months on a wait list, scan this QR, start receiving hybrid support now, the patient is doing that. And we see that again and again with employers, with universities. People adopt it. They are not afraid. They use it. Many times the clinician, the decision maker, there is still fear that the AI is coming to replace us, that we won't be needed, and this creates some blockage. But at the end of the day, even clinicians who do work with technology, with AI, they receive a lot of value and satisfaction. We hear from clinical psychologists that patients are thanking them for this different modality of providing support, and they have a lot of satisfaction because they use their knowledge and their experience that they gained over years to support more people and to help people in an effective way, which they cannot do many times in a one-on-one session on their own. So patients are using it.
Thank you. No, we've got a few more questions, but I'm afraid we're out of time. I'm sure the panelists will be more than happy to answer questions during a different break. So let's give them a round of applause for a very interesting session. Thank you very much.